Right, hi everyone. So this is the next MLA presentation. So the title is breathlessness, but it doesn't really capture the issue as according to neurology, unlike respiratory terminology. So I've sort of rechristened that breathing issues in neurology. So the content will be along how neurological issues can affect breathing, and then specific breakdowns of conditions that can arise in neurological disorders. So type 2 respiratory failure, neuromuscular disorders, which is important in terms of management, how structural issues can affect ventilation and the mechanisms of that, and progressive neurodegenerative disease. And by that, I'm talking about things like the dementias, Parkinson's disease, motor neuron disease, and breathing issues. So the reason that we don't really have people experiencing breathlessness in neurological disorders is that it doesn't tend to give people sort of oxygen thirst, if you know what I mean. So we tend to describe three problems causing breathing issues from neurological disorders. So number one, there are disorders of either the brainstem or the spinal cord, which disrupt mechanisms that allow the process of breathing, respiratory control. We see that quite a lot in maybe devastating brainstem strokes or hypoxic brain injuries or high spinal cord injuries or fractures. Second is progressive weakness or incoordination of bulbar muscles, and that leads to chronic aspiration and a tendency towards pneumonia. And this is what we see as the majority of progressive neurological diseases go on. There is no way to sort of restore that coordination. There's no way to sort of improve swallow. Some people do end up having peg tubes, but what that does not do is prevent chronic aspiration of saliva and tendency to pneumonia. And if there is neuromuscular weakness from any number of conditions like motor neuron disease, Guillain-Barré in the acute phase, CIDP in the more chronic phase, things like motor neuron disease, you get progressive weakness of the diaphragm, the intercostal muscles, and that leads to type 2 respiratory failure. Now, with the brainstem and spinal cord, you need your bulbospinal respiratory pathways in order to automatically trigger breathing and to keep breathing. And if these are damaged, then you can get paralysis of the respiratory muscles and people just are unable to breathe independently. So the phrenic neurons in humans are between C3 and C5. If you've done any sort of neurophysiology, you'll know that in other animals, they can be at different levels. If you have a spinal cord injury above that, C1, C2, then there is a possibility that people will not be able to breathe independently going forward, and you may need permanent intubation and ventilation. In a spinal cord injury, how significant or the density of the injury and the extent influence the outcome and whether people will breathe independently or partially independently going forward. If there's significant brainstem damage, people may not have the breathing drive anymore, and it may also affect their consciousness. So people may be unconscious and lose other reflexes, such as the triggering the ability to breathe. Moving on to neurodegenerative disease, generally, and as a neurodegenerative specialist, as these diseases progress, they all tend to ultimately lead to an end stage of chronic aspiration, pneumonia, and that's what the majority of people with neurodegenerative diseases tend to die of. And in that, I'll include, dementias of all kinds, but obviously Alzheimer's is the most common. Motor neuron disease, but remember that motor neuron disease leads to progressive muscle weakness. So you also get type 2 respiratory failure because you get weakness of respiratory muscles. And Parkinson's disease also leads to progressive weakness and incoordination of swallowing. The breathing, the swallowing becomes more disordered. People find that they need thicker and thicker consistencies of fluid, for example. They might not be able to swallow solids anymore. Speech and language therapy, try and give maneuvers and have puree diets. But you begin to have episodic and then chronic aspiration. You can often hear sort of gurgling as people aspirate saliva and or food and fluid into the lungs. This tends to go hand in hand with speech deteriorating and more frequent respiratory infections. We mentioned peg tubes. There is an assumption that peg tubes will remove the risk of aspiration. It doesn't. It can improve quality of life if eating is very difficult and laboured and it takes a long time for people to finish their food. But what it doesn't prevent is chronic aspiration of saliva. And so there will always be that risk of aspiration and pneumonias. And then we go on to neuromuscular weakness, and I'm including neuromuscular junction disorders, specifically myasthenia gravis. So when you get weakness of the respiratory muscles, mainly diaphragm and intercostal muscles, this can lead to type 2 respiratory failure. So the CO2 rises, and then you get drowsiness, which can lead to reduced consciousness. Now, remember from your respiratory principles that if you then flood the patient with oxygen, so if you put a high flow oxygen on them, you're removing what respiratory drive they have, which is a hypoxic drive, a low oxygen drive. So they can just sort of drift into unconsciousness and pass away. So you need to be really cautious about giving oxygen in the context of type 2 respiratory failure. Now, how we would manage this in an acute setting for things like myasthenia gravis or Guillain-Barré is we would try something like non-invasive ventilation to try and blow off the CO2 and or intubation and ventilation. With motor neuron disease and progressive disorders like that, there needs to be careful discussion of the ceilings of care. Quite often patients have NIV, but they may wish to have that removed after a period of time or a period of decline, and palliative care is often closely involved with that. There can be type 2 respiratory failure from acute disease like Guillain-Barré or botulism. Botulism has been in the newspapers recently as I record this from aesthetic practitioners. And there can be type 2 respiratory failures in established disease. So if you have no motor neuron disease or myasthenia gravis, for example, you could have an infection, maybe aspiration, and then that can worsen the weakness acutely and lead to a sort of superimposed acute on chronic breathing dysfunction, type 2 respiratory failure. So in practice, don't stop treatment. So if somebody comes in and they're in type 2 respiratory failure with myasthenia, for example, they probably can't swallow. Don't just not give them their medication. So they're not going to improve if they don't have their regular medication. Try and get an NG down and get their medicines into them, or seek prompt help from a neurologist, critical care, and so forth. Things for acute exacerbation of diseases like myasthenia or CIDP, or the acute presentation of GBS, which causes weakness of vulvar and respiratory muscles, they will be helped over weeks and months by IVIG, but it won't address the urgent breathing issues. And that's what's going to kill the patient. So you need to have critical care involved, looking at things like support of the airway and considering intubation ventilation if appropriate. So have a low threshold for that. Just a few practical things that I think are helpful. Can the patient speak in full sentences? If they can hold up their head, speak in full sentences, not petering out, that's a good sign. Are the axial muscles weak? That's a good surrogate for bulbar function. So is the head flexion and extension strong? Can patients lift their head up from the pillow? If you ask them, can they expand their chest? That suggests that the muscle function is quite good. Forced vital capacity is very helpful. FVC, I always say Foxtrot Victor Charlie, because some people then give me the full blood count over the telephone, but more practically a single breath count. So in a young person, I would expect someone with no respiratory disease, I'd expect them to be able to get to 30 in one breath. If somebody is a bit older or has concomitant respiratory disorders, I'd still expect them to get into double digits. If you're getting single digits and it's declining, that's an emergency. You need critical care to help support their breathing. So breathing is controlled by nerves, muscles, via the brainstem and the spinal cord. Injuries at the level of C3, C5, or above that, or involving the brainstem, can affect the ability of the drive to breathe. Degenerative neurological illnesses cause incoordination progressively of swallowing, lead to chronic aspiration and a tendency to pneumonia. Neuromuscular weakness, and I'm including neuromuscular junction, can lead to type 2 respiratory failure, drowsiness, and respiratory arrest. So some things to kind of assess that are conscious level, axial strength, force vital capacity, and breath counts. Urgent critical care is what's needed here. And remember that MND can incorporate both chronic aspiration, tendency to pneumonia, and type 2 respiratory failure from weakness of the respiratory muscles. Thank you.